Hello, everyone, and welcome to today's webinar, Streamlining Respiratory Virus Testing with Molecular Diagnostics Impact on Patients and Laboratory. I am Sydney Panilla of LabRoots, and I will be your moderator for today's event. Today's web seminar is presented by LabRoots and brought to you by BD. To learn more, visit bd.com. We encourage you to participate today by submitting any questions you may have during the presentation. To do so, simply type them into the Ask a Question box and click Submit. We will answer as many questions as we have time for at the end of the presentation. You may also submit any technical issues here as well if you happen to have any trouble seeing or hearing the presentation. All right, I would now like to welcome our speakers. Joining us today is Dr. Jennifer Dien Bard. Dr. Bard is the Director of Clinical Microbiology and Virology Laboratory at Children's Hospital Los Angeles. After receiving her Bachelor of Science degree in Medical Laboratory Science from the University of Alberta, Canada, Jennifer Dien Bard earned her Doctor of Philosophy degree in Medical Sciences, studying the aberrant activation of signal transducer and activator of transcription 3 in the pathogenesis of cancer in the laboratory of Dr. Raymond Lai at the University of Alberta, Canada. She completed a medical microbiology and public health fellowship at UCLA and is a diplomat of the American Board of Medical Microbiology, fellow of the Canadian College of Microbiologists, and a licensed clinical microbiologist. Our next speaker is Dr. Jessie Young. Dr. Young is a medical director of clinical device trials and research at TriCore Reference Laboratories in Albuquerque, New Mexico. He has over 10 years experience in infectious disease, including 3 years working at TriCore in the clinical device trials department. Dr. Young is a native New Mexican and graduated with a PhD from the Biomedical Sciences graduate program at the University of New Mexico School of Medicine, where he trained in molecular virology. To date, Dr. Young has been a part of over 50 clinical trials, many yielding claimed expansions or new EUA/510K approvals. In addition to his role within the Research Institute, Dr. Young also oversees POCT for TriCore Reference Laboratories and holds a position at the University of New Mexico as a clinical assistant professor. Lastly, joining us today for our discussion during the Q&A session is Joseph Mann. Joe Mann is a family nurse practitioner and global medical science liaison, currently supporting point of care and molecular respiratory diagnostics at BD. With that, I would like to invite Dr. Jennifer Bard to start with her presentation.
Thank you, Sydney, for that introduction. And thank you, BD, for inviting me to speak today alongside with Dr. Young. And here are just a list of my disclosures. So for my portion of the talk, the primary objectives are going to be just to provide an overview of viruses as a causative agent of respiratory infections and some of the diagnostic challenges. I will then summarize some approaches to identify viruses and the importance of molecular testing, followed by just discussions on best practice recommendations for diagnosing respiratory viral infections. And then lastly, discussing just how to maximize the use of these types of molecular tests through active diagnostic stewardship. So respiratory viruses can cause a whole range of presentation, from mild upper respiratory tract infections to severe pneumonia, which can even progress further. Definitive diagnosis is critical to allow the clinicians to manage the infections of the patient. And it also allows for timely isolation of infected patients, particularly ones that are admitted into the hospital. The clinical signs and symptoms of acute respiratory tract infections, though, are very non-specific. So the presentation can be typically headache, fever, nasal congestion, etc. And so many of these presentations are not going to be are not going to allow you to pinpoint to one particular virus versus another, which is where diagnostic testing can be very important and helpful. The syndromic testing as a whole has really exploded in the past decade or so, with the start of upper respiratory tract infections as a syndromic panel, and has expanded much further. And this slide is just to kind of demonstrate just how we've really grown as a diagnostic field, but even commercially when you think about companies that are developing these types of assays. But ultimately, the upper respiratory tract infection panel or syndromic panel was the first, and is still a very key panel that is utilized in many laboratories. So there are a wide range of diagnostic tests that can be used for the detection of viruses from the upper respiratory tract. Specifically in the way back when, and even when I trained at UCLA, we were still doing viral cultures, which is a very tedious and really just kind of difficult process in general. There's also antigen test, of course, and as I said, the growth of syndromic testing, this really allowed for the development of waved and moderate complex NAT testing, and followed by, of course, high complexity NAT testing, and even NGS. And if you think back to the pandemic, the SARS-CoV-2 pandemic, all of these options, all 5 of these options, have really been utilized during that time frame as well, and up to even NGS, which is not something that we typically were doing on a regular basis. So highly sensitive and specific molecular testing has really become the diagnostic gold standard for respiratory viral illness. Some of the benefits include allowing that potential to avoid or reduce unnecessary antibiotic use. And in cases of influenza, perhaps allow for antiviral prescription early enough that it can be efficacious. It also would allow perhaps limited use of ancillary testing if you're able to identify the etiology of the patient's infection early. This would allow us to avoid additional testing. Perhaps shortening hospital inpatient admissions entirely, or ED length of stay if you're able to get the results out. And then, of course, optimizing infection control practices as well to avoid the person-to-person transmissions that can occur. And then lastly, although when you think about molecular testing, it typically is thought of as more expensive compared to cultures, antigen tests, etc. But ultimately, there have been studies that have reported the cost effectiveness of this due to some of the other reasons that I've stated here, including antibiotic use, length of stay, etc. So the ISA had published a guidance document in 2020 for acute respiratory tract illness and the use of molecular diagnostics, and they had a really nice table figure here. Let's just thinking about the efficacy of molecular diagnostics. So to determine when to test or when not to test, and this includes not necessarily just the technical efficacy, which is up here. Which includes, whether there are resources available, time to result, the performance of the test, etc., but also the diagnostic decision efficacy and therapeutic efficacy. What will this result actually provide? Will it aid in the diagnosis of the patient? Will it change the probability of the differential diagnosis? And then from the therapeutic side, will this allow you to stop therapy, start therapy? And then, of course, when you're looking at outcome efficacy for the patient, which includes morbidity, but also just overall improvement with or without the test. So how effective would this test be in the patient's outcome? And then overall, of course, societal efficacy as well, when you're thinking about just the cost benefit, but also economic costs to the institution, and just kind of really weighing the pros and cons. They include a vignette that I wanted to just kind of summarize here as well. And this is a pediatric case. And I'm just going to highlight some of the key points, which is really a 4-year-old fully immunized patient, significant past medical history, presenting with symptoms, but vital signs were normal, was breathing comfortably, had no other signs of distress, no focal findings that were found. So with that, this decision was made to not proceed with any respiratory testing, and the patient and the parents would just, reassure that this is very likely just a viral illness and that the patient will recover uneventfully. And then alternatively, when you're thinking about patients that where testing may be appropriate, this would be patients that are significantly immunocompromised, perhaps had severe influenza-like illness, and perhaps if detection of other viruses may also help to influence the decision to prescribe antivirals or to withhold antibiotics. And so this is an example of when it could potentially be indicated. And just to point out, and I think as laboratorians, we are very much familiar with the importance of pretest probability, determining the positive and negative predictive value. But just as a nice reminder, this is something that they included in their document as well. Just to, if you are in a season where there is low probability of a virus being detected, so for example, the typical summer where influenza really isn't running rampant, that testing and a positive test may be more likely a false positive than it is a true positive. So just thinking about that as you are, offering your testing in the laboratory, but also for individuals that are ordering these tests. So this is the guidance document that I mentioned here. And again, just to emphasize the one point that they had, which is that not all molecular studies, although there have been many molecular studies that have demonstrated improvement with regards to outcome and cost savings, not all studies have demonstrated this. And they included that this lack of clarity stems from the heterogeneity and variable quality of published studies, and I completely agree with that. And I think that this stems also from the selectivity of patients that we are testing. So really being able to identify the patients that truly would truly benefit from these types of tests versus ones that do not, because otherwise you're diluting out your data. And I think we're doing a disservice to these types of tests, the respiratory tract tests, but other syndromic panels, when this does happen. And it really does speak to the need for stewardship to really help us maximize the use of these types of tests. So just a quick note on diagnostic stewardship, and really, and this is really to determine what tests to order, when should you order it, how often should you order it, and there are multiple phases. I'll just walk through it very briefly. But you're in the pre-analytical phase, and just to emphasize the role of the microbiologist and the importance of collaborations amongst the other primary teams. To determine the best diagnostic test that should be used, if it should be used at all at this point. And then, of course, even from the analytical phase itself, sorry, it's not moving. Oh, sorry, there's an issue with my slide. Sorry, I'll just speak through it. Sorry, it's supposed to show analytical phase, which is again, the testing of the sample, ensuring that the appropriate method is being used, and it also ties to the role of the microbiologist and the importance of that in that role in that phase, as well as the post-analytical phase. So the interpretation of the results. Being able to, as molecular testing become more complex, it becomes even more important to be able to provide guidance in that interpretation and reporting out phase to really maximize the use of that result, the understanding of the result, but also really the use of the result as well. So I apologize, this slide's not working. Okay. So some approaches of stewardship that can be done within the laboratory. So prior to test implementation, the biggest question is this test accurate? Will it provide actionable results that can help improve the patient's outcome? Does the test potentially improve the workload in the clinical laboratory by replacing a laborious test? I think this is a very important question for labs and for lab staffs, because many of the tests that we're doing, could be additive, but it's very important if there's a test that can potentially replace other existing tests. And this is something where molecular testing for respiratory viral panels is a prime example of being able to do that, being able to replace antigen tests, being able to replace cultures. Once implemented, it's important to really have that strict oversight to ensure that the most clinically relevant population is being tested. So how do you optimize that? And then how do you optimize how the results are being communicated to the provider? It's not really just, okay, we're good to go, let's implement and then walk away. It really does take consistent oversight over the test itself. And especially in the era of syndromic testing, with the ease of ordering and the ease of testing itself, there is this mindset of a need to know rather than a want to know rather than a need to know. So it's really important to really continue to have that oversight. And then lastly, being able to develop perhaps support tools that can help do this, because this is not something that can be done manually. So hard stops and soft stops. Soft stops would be just pop-up boxes with warnings to the provider to really kind of rethink it or reconsider whether they want this test. And then hard stops such as repeat testing, where you require a approval before the clinician can place the order. So discussions on large panels versus small panels, this has been going on for a while, and I have a screenshot of this paper that was published in 2015. So it's been a decade, but it's still something that I think is important, and it's not necessary to say that one test is better than the other, but there is a purpose for both, and it's really just thinking about even that stewardship process, as I mentioned, what would be the best approach at which time. And some thoughts and summaries that came from that was, it's really dependent on the institution, the capacity of testing for the laboratory. Of course, cost is always going to be a factor, especially as we're, typically siloed with our cost centers. And then the overall prevalence, as I said, what seasonality, what season are we in, and what tests would be most appropriate. Looking at the patient, immunocompetent versus immunocompromised, severity of illness, would offering the test inform antivirals or withhold antibiotics? And then the part that we tend to forget, or maybe just are not as exposed to being in the laboratory, is that patient satisfaction and assurance part of, is it helpful to have that result just so that the patient knows that, okay, it's just rhinovirus or whatever it is like that. And then of course, just the reimbursement, which is a very important part for us, and determining which tests that we perhaps should be offering. So just a quick note on the seasonality consideration. This is a year's worth of data from 2023 to 2024 for us. And you can see just the broad range of different viruses that are detected over time. If we're focusing on kind of influenza season, so November 23 to about February, March, you can see there is definitely an increase in influenza during that time, and RSV, versus the season in the spring or summer where influenza declines significantly. So just really factoring that in. And so during flu season, when prevalence of influenza virus is high, this is where perhaps a smaller panel testing may be warranted. And this is typically exactly what we actually do. So this is our algorithm here at Children's Hospital LA. So we have two different panels. We have a small panel that covers SARS, flu, and RSV. We also have certain diagnostic stewardship restrictions. So for any positives or any negatives, there are no repeats allowed within the 10-day mark unless they get approval from the microbiologist. And then we also have a large panel saying no repeats within that time frame. And if it's negative for the large panel, we're also not allowing testing from the small panel because it includes all the targets. And then during influenza season, as we watch calculate the prevalence rates over the months, we do require a algorithm to be put in place. So any prevalence that's greater than 30%, we do ask for them to order the small panel first, because the likelihood of it being positive is just so much higher at that time compared to the smaller panel. Compared to the larger panel. And then, as I said, all repeats have to be approved by us, the microbiologists. And then, in the algorithm, I had many boxes that say no repeats within 10 days. And so the big question that comes up for testing is, how often should a patient be tested? There's really no specific guidelines to determine what the optimal frequency of testing is. And there's typically limited data to demonstrate the value of repeat respiratory panel testing. As I said, because of the ease of ordering and the ease of testing, it tends to motivate widespread ordering and widespread testing. So which can be a bit of a double-edged sword, because you end up testing probably way more than you really need to. And so clinical intervention may be to really optimize that and try to kind of prevent the rise in healthcare costs by implementing certain restrictions. So this study that was done by Dr. Prokop and his group looked at over 21,000 NP specimens from almost 17,000 patients, which 35% were children. They had about a 12% repeat rate within 90 days. And what they actually found was that the odds of a change in test result was optimized if retesting was delayed by greater than 20 days. And within the 20-day mark, 88% of the time it remained negative and 62% of the time it remained positive. And you're only going to see a change in about 12% of that. So we looked at our data within our institution. And at this time, we had a restriction of 7 days for repeat. So we did a retrospective analysis that was published in JCV in 2022 of 1,634 specimens from 608 patients. And these were all pediatric patients. Our positivity was about 27%, and the majority of which was rhinoenero. And you can see the most common reasons for repeats were due to persistent or non-worsening URI symptoms, followed by new and worsening symptoms. And then, embarrassed to say, but there were many just like check for clearance after a positive or, asymptomatic screening, even for a small subset of them. This is the data that we found. Within 7 days, we identified about 217 results, so 24% or so, that had a different result. The majority of which were due to new or worsening symptoms listed here, and many of which converted from a negative to a positive. But overall, it was a pretty small percentage. And then when we looked at it further, the majority of the 78 that had new positive cases, 76, as I said, were for new or worsening symptoms, but the majority were rhino and enero, and many of which were really just dismissed. And when we looked at the median number of days from the initial to the repeat, we found that majority of the time, the results were the same within 8 days. And a different result was after 11 days. So with that, we came to the conclusion that really up to 90% of repeats offered no new clinical information within 14 days for the 70% or 7 days for 90%. New and worsening symptoms likely were the one feature that probably would allow for additional repeats, and typically is associated with a new viral illness. Interestingly, a new specimen type wasn't a great indicator of a new viral illness. So for example, if an NP swab was negative, testing a BAL really didn't offer a lot of new information. And then we looked at this quickly for our 2023 data prior to implementing our additional restriction. And of the 666 repeats during that time, 57 or 8.5 showed a new target that was not previously seen, but many of which were rhinoenero. Of the 57, only 11 were seen within the 10 days of collection, and the majority of which were rhinoenero, and then 3 adeno and 1 SARS. So with that, we were comfortable to proceed with our extension of restriction of 10 days. And again, if there are cases that are warranted, of course, they can reach out and we would approve. But for the most part, this hasn't been an issue, and we've been live for a year. And then, the question also with who and when to test. I think this was really a response with the pandemic, but we, and I believe other institutions, saw just a huge increase in the number of large multiplex panel testing that was being ordered in our institution, to the point where we really wanted to pursue some sort of restriction. So this is a restriction that we put in place last September in 2024. So for any large panel, it had to fit one of these 4 criteria. So neonate less than 60 days with documented fever, daily fever of greater than 5 days without alternate diagnosis, fever or respiratory symptom, as well as being critically ill or immunocompromised. And then respiratory symptoms, and if positive, would allow the clinician to discontinue antimicrobials. If the criteria is not met, basically they have to reach out to us to get it approved. So they have to select one of these criteria to be able to place that order. This was the process in our stewardship effort. So we started, as we were building restrictions in our LIS system or EMR system, we started with education, and then implementation at the end here, implementation of the EMR restriction, as I said, in September. This was, of course, also flu season, so we do recognize that, of course, the volume wasn't just going to drop entirely until our flu or RSV rates increased enough to a point where it warranted just a small panel testing. First off, we did why is it? Sorry, it's not letting me. Okay, sorry. Okay, I think you see this here. So we did compare it to our previous year, so 2023 with 2024 data, just during the time frame or during influenza season, and you can see just the dramatic decrease in the time frame that we implemented the restriction compared to the prior year. There was a 35.6% reduction in testing. In many of these cases, appropriately, they were ordering our small panel for SARS, RSV, and influenza versus the large panel. So that was really promising to see. And so we're going to continue to kind of monitor this data just to really assess the overall impact of it. So in summary, so molecular testing has truly revolutionized the diagnostic approaches for acute respiratory infections. It has streamlined our overall diagnostic workup. Viral cultures is not fast by any means, and it's not easy to read. And antigen testing is just not as sensitive. So molecular really is that gold standard. It can aid in the appropriate management of patients, including not only the diagnosis, but also the treatment and overall hospital length of stay. However, to really maximize the use of these tests, establishing stewardship efforts is truly critical. And if anything, it will really allow us to be able to document the positive patient outcomes, and in the end would allow and help the reimbursement justifications, etc. So overall, targeting the testing for the right patient will maximize the yield of the test itself. So it will aid in us justifying implementing types of tests in the reimbursement, as I said, and then overall hospital finances. And so with that, I'm happy to hand it over to Dr. Young to discuss the BD respiratory viral panel further.
Thank you, Dr. Dien Bard. Really appreciate the perspective shared there. Certainly agree with much of what you said. Thanks also for the kind introduction, and to BD for inviting me to speak today. I am going to talk a little bit about the BD Max respiratory viral panel this morning and some of the use cases here at TriCore Reference Labs, split between both clinical implementations and how I use the assay and the device trials and research groups. Here are my disclosures. And I'd like to begin this morning's talk by pulling a couple excerpts from the package insert for the BD Respiratory Viral Panel for BD-MAX system. You may hear me refer to this as BD RVP or BD-MAX RVP throughout the talk. So BD Respiratory Viral Panel is an automated multiplex system for real-time reverse transcriptase polymerase chain reaction, or RT-PCR. And we do get qualitative detection for SARS-CoV-2, influenza A, influenza B, and respiratory syncytial virus, or RSV. The claims in this package insert allow for testing both on nasopharyngeal and on nasal samples from people with clinical signs and symptoms. Dive a little bit deeper under the hood, I pulled a few other experts, and the system really functions after inoculation of sample into the sample buffer tube, or SBT, by isolating, stabilizing, and purifying total nucleic acid from the particular input sample. This can be done from both UVT or viral transport system or Copan UTM. The eluted total RNA is then transferred to the PCR master mix, where amplification can occur. Interestingly, in this assay, we have a couple of different targeted RNA sequences for the specific viruses that are leveraged in the assay. These are listed here with the N1 and N2 regions of SARS-CoV-2, M1 for influenza A, M1 and HA for B, and the N and M genes for RSV. The internal control for the assay here is the RNase P gene. A perspective from me on this is that the stability of these particular targets has been really good throughout the pressure of mutation that we do see from these different pathogens. So the selection of the N1 and N2 region has shown strong ability to resist that mutation, and the lack of dropouts in this assay has been strong for us through our diagnostic journey since the beginning, end, and middle or continuation of SARS-CoV-2. So I think that's a really nice perspective, as for many of you, you may have seen these diagnostic challenges with given assays throughout the course of emerging variants for, say, SARS-CoV-2. Particularly relevant as we look at the new Nimbus or NB1.8.1 variant that is supposed to be circulating here in North America. The parental lineage of Omicron for that particular SARS-CoV-2 variant does aid most likely to continued detection by BD-MAX RVP here based on the mutations in the N region and the success we observed for Omicron detection with the BD-MAX RVP system. I did want to also quickly show something that's very important to me and often important for laboratorians is an example of the report that comes directly from the instrument. As you can see here, I'd like to draw your attention to the report on the left-hand side. I apologize, no pointer, but hopefully you can bear with me. In the middle here, the qualitative results for the 4 major pathogens, or as you may hear me say, the big 4, are present for the qualitative results. If you draw your attention to A2 and A3, or the second and third rows horizontally, you see that there's COVID positive results, and to the right further, there are CT values displayed in the various excitation emission channels present in the detection profiles. The other result that shows positivity here, besides the very final row for the positive control, is A5. I'd like to use this as an example, and as it shows RSV positivity. For me, it's very critical that we are able to not only see these CT values in clinical trials, but also, as we see on the right-hand side, are able to look into the amplification curves. For many of you laboratorians on the call, you may have experienced sort of the black box assay backends where you're given a CT, or there's even troubleshooting or pre-analytical or assay problems that can become difficult to assess when you can't view these amplification curves. Molecular training for even their technologists, MLTs, MLSs, does give us the ability to look at these and maybe begin to troubleshoot that assay alongside folks. So I'm very appreciative of BD and their willingness to share these amplification profiles. Turning back to our example in A5, we see that in the top right panel, we have the excitation emission for the 530-565 channel. The top yellowy orange line is actually the positive control, but right below that, the next orange line is actually the A5 sample. We can see that this does have an amplification profile, and we can see that this is likely a positive, albeit potentially a late crosser. For me, this is, again, really important in understanding what could be happening and particularly when we are dealing with alternative sample types or when we're looking into the back end of assays for clinical trials. Before I dive more into clinical trials, I do want to talk about how BD-MAX RVP is leveraged here within the clinical lab. I am not a part of that clinical lab or a decision maker there, but the team led by Dr. Carissa Colbreth has done an excellent job of implementing this to help reach the appropriate patients. So for us, BD-MAX RVP is used as a standard care under our Fabric test code. This is the Fabric RSV COVID test. Not all individuals that receive Fabric or ordered a Fabric get all 4 targets. Predominantly, this is a COVID and flu-based test for typical healthy adults. However, this is expanded testing for the RSV target is added for patients who are most significantly impacted by RSV infection. This includes very young pediatric patients and our elderly folks, since RSV can create different symptomatic endpoints in those particular patients. What is really important to me about the BD-MAX RVP, and we'll talk about this in multiple different areas, is that the moderate throughput allows us to add this to the algorithm to make sure that all of our patients are served in a timely manner. So this increases and changes the algorithm where typical normal-aged middle adults are able to get the Fabric test code rapidly, and additional testing for those at risk for RSV detection may be moved to a more moderate throughput platform for specific testing and the addition of this target. I do want to say that at this point, although we're focused on RVP and respiratory testing, the flexibility of the BD-MAX as a whole does allow us to run other assays on the platform concurrently. So in a typical day, BD-MAX RVP may not be the only assay run on our BD-MAXs, whereas the enteric panel, C. diff testing, and methicillin-resistant Staphylococcus aureus testing may also be run on these instruments. Dr. Dien did a wonderful job describing the fine line of diagnostic stewardship and reimbursement, and I wanted to dive into these things a little bit more deeply and just reemphasize some of the points she made. Absolutely critical that we have the appropriate identification and facilitated targeting of the appropriate pathogens, and really this right test at the right time, right patient modality to make sure that we're not over or underserving our population. As Dr. Dien also mentioned, this can become increasingly difficult with the overlapping ICD-10s in these patients. At right, you see a Venn diagram that I think we've all seen in one way, shape, or form, describing just the massive overlap of even just the big 4 for these specific endpoints. One thing that can be said is about the selection of a smaller panel, say a 4-plex such as RVP. You can use it to simplify and serve patients, particularly in high volume seasonal outbreaks where we have just tons of influenza, and only those patients who really need that additional target can be added onto a secondary platform to increase or reduce turnaround times and an efficient delivery of result to the providing physician. I think I do want to interject here again that the inclusion of multigen pathogen-specific nucleic acid targets is really important. I think everybody can think back to SARS-CoV-2 and the S gene dropout many of us experienced as new variants emerged in a global pandemic. The selection of multiple genes is, of course, important for the reliability of that assay and to make sure that we're really getting an appropriate endpoint and that there's not a false positivity. And as Dr. Dien also mentioned, that can help us to determine whether or not we really truly believe the assay output, particularly in a season where we wouldn't necessarily expect to see that. I wanted to continue this discussion and talk a little bit about what might be the sweet spot. Now, I think there is many perspectives on this. As was mentioned, there's a lot of discussion back and forth about leveraging large panels, or do we just do small panels? I think a perspective from us clinically is that I looked into what I call peak week, which is our highest week of influenza season. And I pulled down the metrics from our infectious disease dashboard and was not shocked, like many of you, that 96% of all infections in peak week are, of course, the big 4, SARS-CoV-2, flu, and RSV. In many of these cases, and particularly in that seasonality, more targets are not always advantageous. I think there's multiple different levels, and I want to switch gears here and put my solely laboratorian hat on and talk a little bit about reimbursement. I think many of us, although we're very, very motivated to do the right thing for the right patient at the right time, there is always the back end of, well, are my payers going to pay? Are they going to decline my medical necessity? What patient history must be provided? And I think we're all familiar with the levels, or potentially aware that there's 3 different levels that are commonly accessed. So this is the 3 to 5 respiratory targets, 6 to 11, and 12 to 25. Medical necessity for each, depending on payer and their particular rules, may vary. So your mileage may vary. Maybe your payer will support these, potentially not. But considering these and the reimbursement level for our different labs is really critical to make sure that the lights can stay on. Talking about delivering therapeutics and antivirals and antibiotic or antibody therapies, just targeting the big 4 may allow us to get those clinical interventions on board. Asterisks here for a reason, as the jury's still out on some of these, but if we look at the industry as a whole, our advancements therapeutically have really come a long way to potentially target and treat these different pathogens, particularly the big 4, with essentially rapid light speed compared to, some of the older assays and even things like viral culture. I think another perspective too, and it was mentioned briefly, is that sometimes the large panels can really create a challenge with difficult multi-infection interpretations. Now, there's obviously a lot of clinical history that can be combined with this, but really providing the guidance around these tests can sometimes be really difficult. Now, in the example in the top right, I do believe something like this would be incredibly useful given the right clinical history, but used as a first phase test may be very difficult to understand or to provide guidance to a provider depending on the setting. Another perspective on the sweet spot here is that in recent years, there's been a release of a specific 4-plex respiratory CPT code. This can be leveraged and potentially used with your payers to create a new algorithm arm, or to maybe speed up your reimbursement around these major targets. I think the last thing I'll say here is that MolDX did release some interesting verbiage here suggesting that maybe we would test perhaps 1 virus at a time. While I think we argue a little bit against maybe large panels, I think many of us would also argue, well, it would really slow us down if we have to do COVID alone, then flu alone, and then RSV, when there are sort of smaller, targeted, and reasonable panels for particularly high seasonality. I did also just want to stand on a bit of a soapbox here for just a second and remind folks that there's still a need for centralized PCR testing. There are so many wonderful new diagnostics coming to our realm that, I'm really in support of point of care testing and even OTC, but I think we need to do so with caution. PCR is still preferable in a lot of ways, better LODs, better sensitivity, and nucleic acid targets that are potentially more informative about the present infections. Also, based on the things that we see on market, we still have the multiplex advantage at the lab with multiplexed PCR, particularly for on-market assays. And I would end with a tale of warning where the box at right does show an antigen test that received emergency authorization use. As you can see from this table, the highlights show that the total overall positive predictive value for COVID-19 of this particular antigen test is only about 60%. I don't know about you, but this is particularly concerning to me because this is only slightly better than a coin flip when pressed. And I'm not sure that I really would be comfortable calling that as it stands. This really brings us back to diagnostic stewardship, infection control, and epidemiological reporting. I think this is another critical thing about centralized testing. I think everybody here may be guilty of this, where we go and we take a COVID test and we're positive. I don't know about you, but I will admit in this very call that I don't always call my state and let them know that I am COVID positive based on that at-home test. I do want to switch gears quickly here and talk about my role in the TriCore Research Institute. We primarily run clinical trials and do comparator assay testing for approvals. We've been a part of very many submissions and have a variety of different active platforms. BD Max's role here is really important for us because it is commonly approved by the FDA in these comparator trials. And as a 4-plex respiratory assay, we see a lot of these across a variety of different pathogen or platforms as the primary or predicate comparator in these trials. The larger panels are even not favored by the FDA because they can convolute the data sets, and they're oftentimes not that informative, particularly when we're comparing, a 2, 3, 4-plex assay. We don't need a 22, 23 pathogen panel to compare against. Something that may be knowledge to you is that a lot of the point of care and over-the-counter tests that are coming to market are still required to be compared to RT-PCR standards. As Dr. Bard also mentioned, this is still considered a gold standard. The BD-MAX RVP assay fits nicely into that and allows us to use it as a comparator for all different phases, whether it's high complexity, mod complex, and even CLIA waived. Right now, we're currently leveraging BD-MAX on trials for 510K and emergency use authorization, though EUA is primarily being used in the background as a springboard to 510K. I would like to quickly mention that indications and claims in package inserts really matter to me, and congratulations to everyone that the FDA did not necessarily challenge the LDT rule, but this could have become really important in our phase where whether we had the right specimen type, whether that's nasal or nasopharyngeal, we may have had to run an LDT on a respiratory assay just to run a nasal sample. And this was actually very common about 2024 when many common names and platforms did not have claims for both even nasal or nasopharyngeal for 4-plex respiratory assays. I wanted to take a quick step into the diverse use case for us. Something that's maybe not obvious about device trials is that we do receive samples in bulk or in shipments as our couriers come. However, we can also sometimes receive samples one at a time. The flexibility and the diverse use case of the BD-MAX RVP assay is very useful for us. As this flowchart suggests, from left to right, we do receive these samples. We move 500 microliters of sample into the SBT for stabilization. These are then organized into racks for testing on either one of our 2 BD-MAX instruments. The unique rack system allows for 12 samples in each rack. So in the image on the bottom right, there's 2 12-sample racks present, allowing processing of 24 samples at one given time. These will then be loaded into the card indicated by the red arrow, where this can happen. After happening, the racks can be replaced with new samples, and the second card on the right-hand side can then be loaded, allowing us to process 48 samples per instrument. This really gives us open access to move through assays quickly and to progress throughout our day for a variety of different tests. This random access and flexibility of the contained cartridge is important. As I mentioned, we may get a single test. We may have to run through 400 tests daily. Because of the 1 to 48 assay flexibility on a given run, we can really leverage this to our favor. Something else that's really important to me is the contained cartridge system. In the top right, you see a version of the cartridge. You see here from left to right that there's lysis, inclusion of extraction, the master mix, various washes, and then actually at the far end, there are the pipette tips. In the top right image, you actually see a technician clicking in some of these reagents to allow for flexibility, and there's even the ability to expand this into an RUO or a research assay for your own purposes, should you want to do that. This random access is really important to me as I can load different things at different times at different paces. In the bottom right, we see that there's 2 different processing statuses for the 6 samples on board. The first 4 are a little further along than the last 2, and this really gives you a nice visual readout of where you are and allows for the flexibility to process differentially throughout those runs. For me, the reusability of the system is also really important. On this slide here, I wanted to talk through this very quickly, but you can see here that even among the 2 racks, I have RVP assay on the left-hand side and enteric panel on the right-hand side. As a very simplistic example of how this works, RVP may be processed and moved into the card at the left, and the enteric panel may be processed and moved into the card at the right. This allows us to really move through a variety of different assays quickly. And what's really, really critical to me is that these assay cards, although it's only 3 samples, I don't have to throw that away. For those of you using large multiplex, high throughput platforms, you may be familiar with a 96 well format, wherein if you only have a few samples, the other 50, 60, even in this case, 92 wells may not even be used for the processing of that test. Now, speed and flexibility is always important, but performance is critical to us. We see an anecdotally low UNR and invalid rate from these instruments, And as you can see here with the simple qualitative method comparison between the SARS analyte specifically, the Cepheid 4-plex assay, and the BD-MAX RVP, we get fairly strong agreement of approximately 92%. When leveraging some of our panels in the bottom left, you can see that a CAP survey SARS-CoV-2 for 2 different lineages was tested on 3 different platforms, BD, Cepheid, and Roche. And we see that there's relatively the same performance and similar CT values for both lineages. Last year at ASM, we provided a further perspective on the influenza A target, specifically comparing influenza A detection on the Panther Fusion 4-plex assay and the Quidel Lyra assay. Here we see that performance is very good between all of these. Agreement is strong. And what's really important for me, as these were the incumbent assays at the time, that we have strong indicators for continued use at both the high and low CT ranges based on this data set. So in summary, the BD-MAX RVP assay is used both clinically and in research settings, really focusing on the right test in the right time, first to deliver the right test to our patients, and then for me to deliver the appropriate data to the FDA to make sure that assays are accurate, fast, and really giving us the appropriate result. The flexibility is key to my success in the ability to process multiple different assay types, as well as to process from 1 sample up to 48 without generating tons and tons of waste. And lastly, it's really important that this has remained competitive performance-wise in comparison to other contained incumbent systems here at TriCore. With that, thanks again to BD for allowing me to talk today, TriCore Reference Labs, and the TriCore Research Institutes. And I would like to offer time for questions.
All right, perfect. Thank you, Dr. Bard and Dr. Young, for your very informative presentations. As we will now start the live Q&A portion of the webinar, I would like to welcome Joe Mann to join us now. And to our audience, if you have a question that you would like to ask, please do so now. Just click on the Ask a Question box located on the far left of your screen, and we will answer as many of your questions as we have time for. Okay, Joe, over to you.
All right. Thank you so much, Sydney. And thank you, Dr. Dien Bard and Dr. Young, for those wonderful presentations. We have a bunch of questions to get through here. So I'll start with Dr. Dien Bard. I believe this one's for you, given your clinical background. How does the test strategy differ in your experience in transplant patients versus community patients regarding molecular respiratory virus testing?
That's a good question. So I think how testing strategy differs in transplant patients. I do think that, I guess I will start with the caveat: the majority of the patients that we do see and treat here at the hospital are not particularly from the community, unless they're presenting, in the ED or school with a severe acute symptoms. In that way, they would really be kind of treated in the same category that we would for others, and especially they would likely fall under the immunocompromised category, depending on how they are presenting. There are some guidance for specifically for solid organ transplant recipients, but from the American Society of Transplantation Infectious Disease Community of Practice, that does recommend testing in patients that are presenting with symptoms. But I think the key part of that is to help determine whether they should be treated or provided with any sort of therapy. So I think the questions are still the same. It's what are you going to do with that result? Is this going to allow you to manage your patient more appropriately, whether it be transplant patient or no transplant patient? And so I do think the approach can still be very similar. Your baseline to determine whether to treat or not to treat may be a little bit lower for a transplant patient than it is for others, but you still have to kind of take that into consideration. Are you going to actually do anything with that result to determine whether you should be?
Thank you, Dr. Bard. And next question here is for Dr. Young. I think you spoke to this briefly in your presentation, but open versus closed systems for respiratory virus molecular tests. What's your perspective on the differences? Do you lean towards one or the other? Interested to hear your thoughts on that.
Yeah, thank you. And great question. I think for me, I often lead towards a closed system, but it really is dependent on your lab and your pre-analytical process. I think there's use cases for both. Open systems, obviously, we think of the big, larger platforms that have open plates that are incubated on open services within those instruments. I think if you're going to leverage those, there's nothing wrong with that. Just make sure that you're doing the appropriate verification validation and that you're aware of any carryover and the plating strategy of those instruments. It may be surprising for some of the audience that they're not as atypical for many of us that have, broken our wrists pipetting over the years. You load A1 to A2. That is not how these systems do it. They often do checkerboard strategies or other strategies may impact how that carryover is assessed. For pure speed, accuracy, you need a result right here, right now. I think closed systems offer a lot of benefits. The reduction of transmission, being from the point of care aspect, closed systems are really important to me because it reduces pre-analytical risks. But again, it really depends on what your need for throughput is, what your patient setting is, and how controlled that lab environment is, and the awareness of the team to potential carryover risks.
Thank you, Dr. Young. And our next question here is for Dr. Dien. So when it comes to reimbursement issues, do you run into any reimbursement issues at CHLA when testing with small panels and then reflexing to a large panel, i.e. because some of the targets are the same and there's overlap between the small panel and the large panel?
Good question. So, the general rule of thumb, not necessarily just at our institution, but overall, is that if you're going to run two panels where there is overlap, that I believe, you are really only allowed to bill for one. So in this case, if you're running both, you likely would bill for the larger one. I would say that we typically do not encounter, these issues because, one, we're not necessarily recommending large panel testing for patients that are not going to be admitted. And then if they are admitted, they all fall under the DRG anyways. And so at that point, there really isn't that much of a reimbursement discussion other than as a whole under the DRG. So it hasn't been an issue for us, but typically the rule of thumb is, you shouldn't be billing for both, I would say.
Got it. Thank you so much. And Dr. Young, we have another one for you. Antigen versus molecular testing. Which one is better?
Bashal Gupta with maybe an age-old argument. I don't know that this question will ever go away, but I think today, in today's sort of diagnostic venue, given a lab space, if I were to receive the same sample and which would I would choose, I would still lean towards the molecular assay. Reasons for that include, depending again on the targets and what we're really looking for and the predictive values of those assays. I think right now, as a massive overgeneralization potentially, that still molecular assays hold the edge, particularly, as I mentioned in the discussion, when we start talking about multiplexed endpoints, when there's multiple pathogens on a particular lateral flow or antigen test, sometimes those can get messy and those performance metrics do change. And given the example that I put in the talk, doesn't mean that I completely dislike antigen tests. I think they're fantastic for over-the-counter and making sure that people get the help that they need, assuming that we can connect them with physicians who can give them the guidance to receive the treatment that they need.
All right. Thank you, Dr. Young. I'm going to take this next question. Does the BD respiratory panel include atypical bacteria like Mycoplasma, Chlamydia, Legionella? No, it does not. It currently, the BD Max respiratory viral panel only targets SARS-CoV-2 influenza A, influenza B, and RSV. We also offer on the BD-MAX system a SARS-CoV-2 standalone assay, and that comprises our respiratory portfolio on BD-MAX. And I apologize, this next question here, I don't know who it's intended for, but I'm hoping Dr. Young and Dr. Dien will help me out with this. One of the attendees is asking for a quick recap on the part of molecular detection of the virus and the mechanism through the lab automation, through which lab automation is performed. Do you know who that's intended for?
I am not sure. I think I can speak quickly to the automation component. I think for the BD-MAX system, it is a little bit more manual for the closed cartridge system here, but there is opportunities to really increase efficiency by taking advantage of that still manual process and not solely relying on the instrument. Something that we do to increase efficiency is set up multiple racks. So the image shows 2 different racks in the instrument, but while that's processing and moving through, we actually prepare the next set of racks. So although it's not true automation, leveraging the BD system for multiplexing and what they call interleaving officially really allows us to be more efficient there. I'm not sure that I answered the question. Maybe Dr. Bard, do you have a second thought there?
Yeah, I guess I'm not particularly sure what the question was asking, but I do agree with what you said, Dr. with regard to that, and at least just the automation part. Yeah.
All right. Well, I want to be cognizant of everyone's time. We're 2 minutes past the hour here. I think we can wrap up, and I'll send it back over to Sydney to close out.
All right, perfect. Thank you, Joe, and thank you again, Dr. Bard and Dr. Young, for your time today and for your very important research. We would also like to thank LabRoots and our sponsor, BD, for underwriting today's educational webcast. Before we go, I would like to thank the audience for joining us today and for their very interesting questions. Questions that we did not have time for today and those submitted during the on-demand period will be addressed by the speakers via the contact info you provided at the time of registration. This webcast can be viewed on demand. LabRoots will alert you via email when it's available for replay. We encourage you to share that email with your colleagues who may have missed today's live event. Until next time, take care, everybody. Goodbye.
Thank you.